Thank you very much. I'm greatly honored and pleased to be here. I thought the translation facilities were for me, but I do still speak French. And I'm interested in discussing weaning protocols with you. And I'll do that following the general title we have for this session of Proven but Underused. I have a number of conflicts of interest here. We've worked with a number of mechanical ventilation firms. Now, very quickly, I think most of you know this. There's interest in weaning from mechanical ventilation. This is obviously important because all patients that survive mechanical ventilation have to go through a weaning period, and a number of studies have shown that a substantial amount of time is spent on ventilation, and it's all a bit vague because no one really knows when weaning starts. And because mechanical ventilation is associated with a number of key complications, any time that can be saved on mechanical ventilation is obviously weaning time, and so we should have a more scientific focus on this, more scientific than what was done before the 1990s. We should really focus on the question of mechanical ventilation weaning. Here we have a classification where we try to use the same terms. I'm not sure that we've actually succeeded in doing so. You have so-called simple weaning, which means on the first attempt to wean the patient can breathe spontaneously. That's most patients in intensive care. And then there are so-called difficult weaning cases where you need to make a number of attempts, and that's been set at an arbitrary limit of a week. And then there's the third category, which is called prolonged weaning. And these are patients who've had a tracheotomy and they spend weeks or months in intensive care units. And these are different issues that have to be dealt with. The idea is that we need to focus on this part of ventilation, and previously it was meant to be determined by the patient and his development. Now, obviously, that's a question of weaning a patient when he's better. And then there was the paper which said we needed to have a specific focus on this issue, and that a team should be set up specifically to deal with this stage. It's a ventilatory management team, and they reduced the period of mechanical ventilation, the reduction in the number of blood gas measures and other acts. And so that was an effort which caused a reduction in the period required for mechanical ventilation. In 1994, we published the first multi-center study of weaning, and this conclusion has been kept since. And depending on the type of ventilatory approach that you have, whether it's a ventilation mode or not, it has a huge impact on the time the patient spends in mechanical ventilation. There was a 5-day group there where 70% of patients were weaned, whereas with the other group there were still 60% that had not been weaned. So it's a question of the type of approach. And then the following year, there's Esteban study, which was published, and it showed that VRC was the worst modality. But again, it depended on the ventilation strategy. And then there was the pivotal study which said that there should be a systematic approach. There should be screening first. There should be daily screening of patients to see whether they were potentially in a position for spontaneous breathing. And that's a different approach because you keep the patient with the case under mechanical ventilation. You don't know if the patient can breathe spontaneously or not. Now, there were very simple criteria, PO2, PEEP, and so on. And if the criteria showed that there was a possibility of spontaneous breathing, they were given a spontaneous breathing trial for 2 hours. And then the patient was extubated or not, depending on the results. And you can see there was a considerable, quite spectacular drop in the period of ventilation without any greater complications such as reintubation. And this was the pivotal study for later studies. And it showed that there had to be a systematic approach to weaning, because if it's not done in a systematic way, if you don't ask the right questions to see if the patient can be extubated and breathe spontaneously, then you're going to miss the target and the period of mechanical ventilation will be extended. And then on the basis of that data, there was a general excitement on the idea of having protocols. There had to be protocols with studies such as this one here, which showed if you randomize one arm, where you just have the doctor deciding on the weaning compared to a protocol. There was a study where there were 3 different protocols, so 3 different weaning practices, and it showed that there was better results using a protocol than without a protocol. It's a fairly strange concept. You saw the previous studies which showed the type of ventilation which got different results, and then in the end they said what was important was to have a protocol. But a protocol is a term which I think is completely vague and nebulous. And this is an answer to one of the questions asked, why don't we use it? Because I don't really know what a protocol means. Sometimes it means a general plan, a general guide, what you do in practice, and how you decide in one department to deal with this issue, doing it together as a team. And in other cases, it means that everything is set down in writing. You have a respiratory rate above 30, less than 30. This is what I'm going to do. He's in coma or not in a coma. This is what I'll do. In other words, you delegate the medical decision to a flow chart with a set figures as guidance which have been written down. And that's very complicated. It's very complicated to implement. I took the data which is Gaëtan Bédunot's study. It was shown earlier today at this Congress. And this tried to find the classification between simple, difficult, and prolonged weaning for patients in a prospective study, which included around 40 intensive care units in France. And this is the classification which they found. And the most interesting piece of information here is that 50% of the patients could not be classified, because the patients or the doctors or the teams were not doing what they were expected to do. In other words, to follow the weaning protocols. So there were patients who were extubated without a spontaneous breathing trial. There were patients who didn't go through any weaning process, but they were just extubated. There were some patients that had a tracheotomy, so it's a different process. So there was use of post-op NIV and so on. Others who weren't interested in the protocol. And when you look at the real situation, it's of course much more complicated than a simplistic theoretical approach you may have for implementing a protocol. Having said that, this of course doesn't stop you going and looking at studies, and people can carry out meta-analyses. And here you have the results of a study. This is a very recent study here. These are studies that used spontaneous breathing protocols compared to those without protocols. And here you have studies which used a ventilation reduction protocol compared to those without protocols. So you've got the little diamonds that are in favor of the protocol here. It seems to me that there's no study that's positive, but they find that global is good, but this isn't very convincing. So here we have a protocol. What is a protocol? It's something like this where you have everything written down. And you forget about the clinical assessment. You've just got figures and you base your decision on that. This is always cited when you look at the meta-analyses, and it shows that there's a positive impact of protocols. Here you have the graphs showing weaning. This is in medical intensive care units. This is after surgery where it was tested. Now, after surgery, there was no effect whatsoever. And perhaps it's difficult to convince people in intensive care units that they should follow a protocol because there's no effect produced by the protocol, by the use of the protocol. Perhaps the most rigorous study is this one here, because unlike all the other studies, it was the same approach for both arms. One had a protocol, and the other was just clinical assessment, but there was the same overall strategy. This is a very well done study, very convincing, and it shows that there's no difference, and there's a discussion about a number of patients whose extubation was delayed because the protocol was used. And there's discussion. It was very difficult to say that there was no benefit from using a protocol, and they said, well, it's perhaps because there are lots of us, and every day when we visit the patient, we have a discussion as to whether the patient should be extubated or not, and perhaps the protocol is better when you have smaller teams and fewer personnel, and that's an idea that could perhaps be explored. And if you already have daily discussion as to whether the patient can breathe spontaneously or not, then there's no added benefit from using the protocol. Then if you go back to the ALI pivot study, or SLE study, this is research study, so you've got research protocol. You can't really say that it's a healthcare protocol. That's a bit too much. And of course you have to look at the control group, and the control group gives you the VACI at 70%. Now this is the comparison. They say this is the worst way of weaning patients, and so there is the use of a protocol, but I certainly wouldn't cite this study as an argument in favor of using protocols. This is another study which is often shown in favor of protocols. It's quite amusing to look at this. You could say that it's a weaning center. There were patients who were difficult to wean, so it was the second group, and the third, the prolonged weaning group. And they compared two protocols, PSV and one piece, and they didn't find any difference. And then they said they had to compare it to their historic data before going on to use one or other of the protocols. And they found that compared to their standard clinical practice, that the use of a protocol did reduce the time required for mechanical ventilation. But when you look at this Kaplan-Meier graph and the time where the patients are not under mechanical ventilation, you can see that there's a difference here. They decided for the protocol that they would test the patients who are sent in for difficult weaning to see if they can be weaned or not. And all the differences at the beginning, they realized that the patients who were referred to them were not necessarily difficult weaning cases, and that all the rest was the same as the previous graphs. Any use of the protocol after the initial test doesn't have any impact on the reduction of mechanical ventilation. It's just a question of the initial screening. So the idea of systematic screening, the initial stage to see if the patient can have spontaneous breathing, is an important idea that comes back quite often. Then there's the difficulty of comparison of the automatic weaning methods. And you know that I have a major conflict of interest here because I was one of the inventors of the smart care technique, which has been marketed. And this has been tested in more than 12 trials. And when you look at all the meta-analyses together, you can see that there are effects which are highly significant in favor of the automated method. More than 5 days reduction in weaning time and hospitalization. And it's difficult to interpret it, because here we have a study by Karen Burns and Francois Lelouch. They conducted this study in Canada. That was before I went there. And it showed a major advantage in using the automated system compared to a very strict weaning protocol. They said, okay, but the control arm of other studies didn't have a strict weaning protocol. So perhaps when you consider this compared to a strict weaning protocol, this is the most spectacular finding. So when you look at all that together, it's difficult to see what's happening. It's difficult to say that protocols covering the entire weaning period are really the panacea that we need. And when it comes to extubate a patient, it's a clinical decision which is very important, and you need to have the clinical practitioner thinking about it to see whether it's possible or whether there's a major risk in extubating the patient. Now, this is a review which we did with Arno, and this is where you can get high mortality, excess mortality with failed extubation. And if you decide to extubate and the person who doesn't have successful extubation has a mortality rate between 30 and 50%, and so this is very high. They're very serious cases. Now, this is retrospective data that we have here, and you can see the SOFA score, the organ failure score, is the same for patients that are successful in failure, and you can see with those who have failed extubation that it's much worse. So I would say that's a clear message to say that failed extubation is not just a marker. I would say that it's a factor which makes the patient's condition worsen. And so extubation is a decision which must be a medical decision and an individual decision. You can also look at it as seen from the patient's point of view. This is a very good study here. The patients were interviewed before the decision was made to extubate them. They said, what do you think? Do you think that things are going to go well or not so well? Now, in patients who thought they were going to get a good result from extubation, there were very few failures. These are patients where the decision had been made to extubate them, and it wasn't the patient who decided. And when you have patients who weren't too keen on the idea of extubation, you have a failure rate which is greater than 50%. Okay, you can try and factor that into the protocol. You can have an extra question as to what the patient thinks about it. But as I see it, I'd say there's still a lot of work which has to be done in the area of weaning. And I think it's a bit early to say that protocols will solve all of this. I'd say it's a question of common sense, and it's obviously common sense that these protocols are not used on any systematic basis. Thank you. Thank you very much.